So thank you so much. Thank you so much, Dr. Amna. We are headed towards the last session of the day, and probably I'll get to it right away. I'll have to make two announcements. Number one, please kindly listen to me very carefully. You are welcome to enjoy with your kids, but outside the hall, please. We need to maintain the decorum of the hall. So I request anybody who is accompanied by the kids, kindly do enjoy with your kids, but outside this hall. Number two, I really want you to stop talking amongst themselves. The people who are sitting here, the people who are on the stage, every word that they say is like a pearl that you need to understand, that you need to listen. So kindly stop talking amongst themselves and listen to what they have to say. I thank you for this. For the last session, I'll have two of my expert panels, and I'll just introduce them. Professor Najmul Islam, who is the Professor of Medicine and Endocrinology at Aga Khan Hospital. He's the past President of PES, Dean and Convener of Endocrinology in CPSP, and recipient of Lifetime Achievement Award from the PES. I'll request Sir to kindly join us on the stage, please. Our second panelist of expert is Professor Tasneem. She's a laureate award winner by United States Endocrine Society. She's retired executive director of JPMC. She's Dean Medical Institute of Diabetes, Endocrinology and Metabolism, and Director Medical Institute of Diabetes and Endocrinology and Metabolism, OMI. Thank you, ma'am, for joining us here. I'll take this opportunity to introduce our speaker, Dr. Abd Tahrani. He is International Medical Vice President for Obesity in Medical and Science, Obesity MASH at Novo Nordisk. He is recipient of Scope Obesity International Fellowship by World Obesity Federation. He is Honorary Professor of Medicine at University of Birmingham and Honorary Consultant in Endocrinology, Diabetes and Weight Management at University Hospital Birmingham NHS Foundation. And he will be talking about the right GLP-1 receptor analog for the right patient, for the right reason, I would say, in obesity management. Professor Abd Tahrani, please. Thank you.
Thank you very much for the very kind introduction, and I thank the organizing committee for giving me this opportunity to be present in Pakistan again since my last visit about 3 years ago. It's always a pleasure to be back in Pakistan and see many old friends and colleagues. So today I was asked to talk about the role of GLP-1 receptor agonists in the management of obesity and diabetes, with a particular focus on how to choose which GLP-1 receptor agonist to which patient. This is the agenda of today. I will cover a little bit of background about obesity pathogenesis, but I will also talk about the role of GLP-1 receptor agonists in obesity and diabetes management, and hopefully provide some advice to the treating clinicians about how to choose between the different agents available. That's my main conflict of interest, that I am an employee of Novo Nordisk and a shareholder of Novo Nordisk. It's not surprising to this audience that obesity is really very common. Just under 1 billion people in the world currently are affected by obesity, and this number is expected to reach 1 billion by the year 2030. Most countries in the world currently have high prevalence of obesity. More than half the countries in the world have a prevalence of more than 15% of their population who have obesity. That's not to mention overweight. And this didn't happen suddenly. The prevalence of obesity has been increasing for the last several decades. Despite all the policies we have, despite improvements in treatments, the prevalence of obesity kept increasing. And it kept increasing across the whole globe. So multiple regions in the world. It's not just in one region, across the whole globe. But is it really a problem? Why do we need to care? Why do we need to treat obesity? The reason why it's important to address and treat obesity is because obesity has a major impact, adverse impact on health, and also a major impact on health economics. But today I will cover mostly the health impact. I will not talk about the health economic impact. Obesity is associated with more than 220 complications where there is evidence that obesity management can reduce their risk. Some of these complications are metabolic, and you are all familiar with these diseases. You probably see them in every day of your practice life. Some of them are mechanical, and some of them are related to the mental health of the patient, such as depression and anxiety. Not only that obesity is associated with increased risk of many complications individually, we also need to remember that obesity is one of the major drivers of multimorbidity. And currently, there is an increased interest in all major healthcare systems and also amongst payers for healthcare systems about, instead of targeting individual diseases, they want to target the total burden of the diseases on the patient. By trying to treat obesity, we can reduce the burden of multimorbidity amongst people. In this slide, you see a paper published previously from 2 cohort studies. On your left-hand side, there is a Finnish cohort study, and on the right-hand side, data from the UK Biobank. On the y-axis, you see cumulative incidence of multimorbidity. At the top is defined as having 2 chronic diseases, in the middle 3 chronic diseases, and at the bottom, it's 4 or more chronic diseases. The red line is people with obesity, the blue line is people with normal weight. And on the x-axis, you see the age. Thank you. So on the x-axis, you see the age. You can see that regardless of the definition, and at all age groups, people with obesity had higher incidence of multimorbidity compared to people without obesity. And what is also more shocking is that if you pick up, let's say, for example, age of 70, at the age of 70, about 10% of people of normal weight will have 2 or more chronic diseases. If you try to find what will happen in people with obesity, you see that you will have to go to the age of 45 to find out 10% of people with obesity have 2 or more chronic conditions. So people with obesity develop multimorbidity 25 years earlier than people who have normal weight. So not only that obesity will reduce their survival, but also it gives them survival with more diseased years. And this is some of the data consistent with that is the data about survival. So what you see here are survival graphs for people of normal weight, class 1 obesity, class 2 obesity, class 3 obesity. And if you look at the age of 70, you will find that people of normal BMI have about 80% chance of reaching the age of 70. That goes down to 70% chance of reaching the age of 70 in people with class 1 obesity, 60% chance in class 2 obesity, and 50% chance in class 3 obesity. And that translates to about 10 years less survival in people with BMI above 40, and about 4 years less survival compared to normal weight in people with class 1 obesity. So clearly the health disease burden is huge. But despite the huge disease burden, both health-wise and economic-wise, still obesity is largely underdiagnosed. And even if it forget about the diagnosis, and in some health systems, it's important to diagnose obesity on the records, like the US, for example, for insurance purposes, for reimbursement purposes. Despite it's largely undiagnosed, less than 20% of people with obesity receive any evidence-based treatment, including evidence-based lifestyle behavioral interventions, with less than 2% receiving bariatric surgery or pharmacotherapy. So clearly there is a huge access challenge that people with obesity cannot reach or cannot access treatments. One of the most challenging aspects of weight management is that people with obesity regain the weight following the weight loss. This happens commonly after any weight loss intervention, whether it's lifestyle, whether it's pharmacotherapy, or at least some pharmacotherapy, or whether after bariatric surgery. And that difficulty to maintain weight is really a major barrier in treating people with obesity. Most people who try to lose weight with lifestyle intervention will regain the weight. And that weight regain is driven by neurohormonal mechanisms. It's nothing to do with the patient's willpower. And I'll explain what these are in a minute. But this is just an example of one systematic review that looked at all the trials looking at lifestyle interventions that had at least 3 years of follow-up, and they managed to achieve at least 5% weight loss during the intervention. And what we can see that during all these trials, there is good weight loss, but during the follow-up, almost all the weight lost has been regained, and some people even overshoot. There's one exception in this trial that has a huge amount of loss of follow-up, so that the results of this trial are doubtful. So on average, lifestyle interventions cause significant weight loss, but there is significant weight regain over a period of time. And if we look in real-world data, for example, this is trial data. But if you look in real-world data, there is data, for example, from the UK, which shows that every year, about 10 to 20% of people with obesity actually lose about 5% of their weight. And that's great. But the sad part of it is that half of them will regain it in 2 years, and 80% of them will gain it within 5 years of follow-up. What that means is that, yes, there is 80% who regain, but also it means that for 20% of people who actually manage to maintain their weight loss over a prolonged period of time, lifestyle interventions is truly the best treatment option for these people. It's the most cost-effective and the safest treatment option. But also it means that for those 80% who don't respond to lifestyle interventions, we need to do something else for them. We need to escalate the treatment like any other chronic diseases when you don't meet your treatment target. And the reason why people regain weight after weight loss is because when people lose weight, the body reacts. And the body reacts by increasing ghrelin, which is a hunger hormone. It also reacts by reducing the level of fasting and postprandial, especially postprandial, satiety hormones, such as peptide YY, cholecystokinin, and GLP1. At the same time, the mitochondria across different organs become very efficient in energy production, that the body goes into an energy saving mode and drops the energy expenditure. But the drop in the basal energy expenditure after weight loss is more than what is predicted by their weight. So for example, if you take somebody who is 80 kilos and they drop to 70 kilos, and you compare their energy expenditure to someone else who's always been 70 kilos, you see that their energy expenditure is much lower. So there is a discrepancy between the predicted energy expenditure and the observed energy expenditure after weight loss. This is called metabolic adaptations. So if you put all of this together, after weight loss, the energy expenditure goes down, the hunger signals goes up, and the satiety signals go down. What do you think will be the outcome of this combination? Weight regain, because people are going to eat more often, they are going to eat more at each time because of the lack of satiety hormones, and because of their lower energy expenditure, they end up also gaining weight. And the reason the body reacts to weight loss is because fat mass is regulated, biologically regulated. Like anything else in our bodies, everything you measure in the lab or you measure in the patient in your daily practice is biologically regulated. Whether it's your glucose levels, your blood pressure, your heart rate, your sodium levels, your GFR, all of these are actually biologically regulated processes. And fat mass is no different. And the center for this regulation is in the brain. And just to show you an example that actually the body does defend its fat mass, this is a trial in which was done in women of normal weight who were seeking liposuction from the lower abdomen or the hips or the thighs. And the women were randomized into just observe or liposuction intervention. The dark line is the liposuction intervention. So what happens when you take some fat from the body? You lose weight. But what happened for them over the next 12 months? And remember, these are women who's always been thin, so they are always able to regulate their weight within the normal range throughout their lives. They regain the weight, despite taking out a whole lump of fat. And where is that weight is being regained? Based on the body composition data using MRI and DEXA scan, some of it goes up in the thigh, but what's interesting was that the greatest increase was actually in the abdomen. And they go back to the same level as the people who didn't have the liposuction. And most of that abdomen fat was actually visceral tissue. So what we are seeing here is that by removing an amount of fat from the subcutaneous tissue, which is probably largely does not harm health, the body reacted and compensated for that fat tissue within 12 months, replacing the healthier fat with a visceral fat, which is much more unhealthy and more damaging to health. Another example to show how the body regulates its fat mass is this very long-term study that followed up people over decades. And over decades, people BMI class can change. Some of them will start as normal, finish as normal. Some of them will be normal, become overweight. Some of the overweight will have obesity. And over the 40 years, they followed their trajectory. So if you look in this group that started with an overweight BMI, ended up with having obesity BMI, they gained 40 kilograms over 42 years period. When you model their energy intake and energy expenditure data, this will be equivalent to about 20 calories a day of excess energy intake. If you look at the group that started just normal BMI and ended up being just in the obesity range, they gained 15 kilos over 42 years, and the modeling suggests that this is about 7 calories a day of excess calories. What I would like to ask all of you is, how many of you can really accurately calculate 7 to 20 calories a day of excess intake? I think none of us can do that bit. So this is a biologically driven process. This is a process in which the brain controls what's going on. And there is a lot more data, but I'll only show one more of these slides. This is a very interesting study because they managed to find people who are actually very happy to record their food intake on a daily basis for a whole year. And I don't know where they find these people, but they found them. And these people had absolute weight stability over this year. 65 kilos, pretty flat line over the whole year. But when they look at their energy intake and energy expenditure, intake is in green, expenditure in gray, you can see there's a huge variation in their calorie intake on week-to-week basis, which reflects daily variation as well. So they averaged every week together. So there is a huge variation in energy intake in those people that can vary more than 1,000 calories a day. At the same time, there wasn't a huge variation in their energy expenditure, which is the gray color. Some variation, but not a huge. But despite this big swings, they actually maintained their weight over the whole year with no weight increases, no weight decreases. So if you have a system that can flux in and out thousands of calories to maintain your energy balance, this is a biologically driven process. Nobody wake up in the morning and say, today I'm going to have 2,000 extra calories, and tomorrow I'm going to reduce 2,000 calories. None of us do that. And the system that regulates that energy homeostasis is in the brain. There is a homeostatic system, mainly based in the hypothalamus and in the brainstem, that receive neurosignals and hormonal signals from the periphery to regulate to tell the brain how much fat mass there is and how hungry the brain should be. This homeostatic system also talks to the hedonic system, which is in another area of the brain, and that system controls the liking and the wanting, using dopamine, cannabinoids, opiates, neurotransmitters, and a variety of others. The crucial part about these two systems to know is that they are subcortical. They are not in the cortex of the brain. All the different centers are subcortical. What does that mean is that they are not under your conscious control. But these two systems communicate with the executive function center. That's where the cortical part is. And that cortical part make the decision, okay, let's eat. So if you have a disturbed or disrupted homeostatic and hedonic centers, either because of problem in the signals or because of other problems, environmental interactions, for example, if those two centers are bumping, are sending so many signals of hunger to the executive function, keep telling the executive function all the time, eat, 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 that executive function doesn't really stand a chance to say no. Because the system is driven from the bottom to the top and not the other way around. So when we give people bariatric surgery or drugs, we silence those two systems. We don't silence them completely, but we silence those two systems, reducing firing the signals to the executive function, allowing the executive function to say, I don't need to eat. On the other hand, when we do lifestyle behavioral intervention, we are trying to strengthen the executive function to fight the hedonic and homeostatic systems. And that's a fight that can be usually won over the short time and then lost over the longer period of time. Not in everybody, but in the majority. So it's important to just consider how the appetite is regulated when we think about how to treat patients. So with all that in mind, I'll move to the use of GLP-1 receptor agonist in obesity management, and I'll focus on liraglutide, but 3 milligrams, but of course I'll mention semaglutide 2.4 as well. So liraglutide is an analog of a human GLP-1. It's about 97% similar. It has some modification in the structure, in the amino acids and fatty acid chain, and those changes make it appropriate for once daily administration. It also makes it resistant to DPP-4, because otherwise GLP-1 get destroyed in the body within 2 minutes, as you know. And what does liraglutide do? Well, it does exactly what we think it does. It stimulates or enhances the satiety neurons. It inhibits the hunger hormone neurons, and hence it improves appetite control. But as I mentioned, the hedonic system is also important. And what liraglutide does is that, and in this study I'm going to show you functional MRI data. The gray color here is placebo, and I'll show you the liraglutide effect in a minute, where they showed people pictures of delicious food, basically, and they looked what happens to their brain when they get stimulated. And I'm showing two areas, which are the insula and the putamen. Both of them are involved in the reward system, in the hedonic system. And what liraglutide does, it reduces the stimulation of these areas. So people's reaction to seeing the pictures is like, yeah, it's nice food, but I'm not interested in stimulating my brain to eat it. Liraglutide 3 milligrams was examined in a variety of phase 3A trials covering people with obesity and prediabetes, obesity and diabetes, in combination with low-calorie diet. I'll come to that in a minute. In people with sleep apnea, in people who also treated with insulin, and in combination with very intensive behavioral therapy. And the weight loss achieved is between 6 and 8%. 8% in people without diabetes, 6% in people with diabetes. We always get lower weight loss with all interventions in people with diabetes. We can try to figure that out why in a minute, but probably after the talk. But the importance for me on this slide is not the weight loss. The importance for me on this slide is the health benefit. So with the 8% weight loss, there was an 80% risk reduction in progressing from prediabetes to type 2 diabetes. With the 6% weight loss in diabetes, there was a HbA1c reduction. With the weight loss in sleep apnea, there was reduction in the apnea-hypopnea index. And if you want to know the proportion of people who lose 5%, so about 50 to 60% of people receiving liraglutide treatment will achieve 5% or more weight loss, which is about double what you will get from the placebo arm. Unfortunately, those trials do not have a lot of Asian data, especially no South Asian data, but there is some real-world evidence data from South Korea about the use of liraglutide. And the interesting part for me is this one here, that over 180 days, so that's half a year, the weight loss was about 9%, which is probably even more than the clinical trials, where we get on the average population. And also, the 5% weight loss was 86%. So again, at least it suggests that the Asian patients responded at least as good as we think from the clinical trial, most likely better than the clinical trial. And when you look at the relationship between the amount of weight loss and the duration of treatment, you can see clearly that those who actually persisted on the treatment ended up even losing 15% weight loss. You can also enhance the efficacy if you want more weight loss with liraglutide by providing a low-calorie diet before treatment. So in this trial, they gave low-calorie diet, and they took the people who lost 5%, and then they were randomized to placebo and liraglutide. And what you see that they lost 6% on the low-calorie diet, and with liraglutide, they ended up losing another 6%, taking it to 12% overall efficacy. Also in women with PCOS, we see effective treatment. Liraglutide 3 milligrams reduces free androgens in women with PCOS, and improve menses as well in a 32 weeks randomized controlled trial. And for those interested in pediatric, the SCALE-TEEN study showed that liraglutide 3 milligrams improved a whole variety of adiposity-related measures in adolescents from the age of 12 and above. I put this slide here to remind me, because people always ask me, considering nausea is the most common side effects, do people lose weight because they have the nausea? And this is the weight loss in people who have nausea and people who don't have nausea in liraglutide and placebo. And both of them are exactly the same. There is no difference in the weight loss whether you have the nausea or not. Semaglutide 2.4 milligrams, on the other hand, has a greater efficacy, as you can see, in terms of weight loss. Having said that, that's the 2.4 milligrams dose, not the 1 milligram dose. So we need to be careful that the data here showing the benefit for the dose required. And I'll come to that in a second. So coming towards the end now, when it comes to GLP-1 receptor agonist treatment in type 2 diabetes, it's a lot easier because there is the network and meta-analysis that compared all the different treatments, and it clearly showed that the change in HbA1c in drug-naive patients, the highest change in HbA1c or the greatest reduction in HbA1c was actually with subcutaneous semaglutide 1 milligram. And when they looked in people who are having metformin, also the greatest reduction in HbA1c was subcutaneous semaglutide. And in head-to-head clinical trials against DPP-4 inhibitors, SGLT2, and other GLP-1, also subcutaneous semaglutide was superior in terms of its HbA1c reductions, and all GLP-1 receptor agonists have the CV benefit in diabetes. But just remember, this was before tirzepatide days. So this study was not done after tirzepatide. So when you want to choose which GLP-1 receptor agonist to give to your patients, I think there are some basic principles that need to be remembered. The first one is that the response is dose-dependent. DPP-4 inhibitors increase GLP-1 levels in the blood by 2 times, which giving you weight neutrality and modest HbA1c reductions. The diabetes doses of GLP-1 give you greater HbA1c reduction and a greater weight loss reduction. But the highest doses of GLP-1 only give you added benefit from weight loss perspective, not from HbA1c perspective. So it's important to give the right dose to the right indication. And the clinical trials data actually support that. So you can see with increasing dose of liraglutide, you get increasing amount of weight loss. But you don't get much difference in the HbA1c between 1.8 and 3 milligrams of liraglutide. And the same with semaglutide. The 1 milligram causes much less weight loss than the 2.4 milligrams. But when it comes to HbA1c, almost identical. So at the weight loss dose, you need that dose for the weight loss. At the diabetes dose, you get your maximum HbA1c efficacy. So it depends what you are treating. And when it comes to comparing both of these GLP-1s, there is a network meta-analysis, which I will only highlight one result in it, which is comparing semaglutide 1 milligram with liraglutide 3 milligrams. And what they found that liraglutide 3 milligrams was statistically more significant weight loss compared to semaglutide 1 milligram. But the HbA1c reduction was greater with the semaglutide 1 milligram. But for weight loss perspective, liraglutide was superior. Of course, the strongest agent amongst these is semaglutide 2.4. But liraglutide 3 was second in command above semaglutide 1. So just to put this in context, I'm not expecting you, of course, to participate in this, but just to put it in context, you have a 48-year-old gentleman, type 2 diabetes for 2 years, HbA1c 7.8%, BMI 27, on metformin with a history of CVD. What is my interest here, treating his diabetes or his obesity? Of course, I like to treat both, but the priority here is to reducing his HbA1c and give him a drug that reduces CVD risk and probably have a good weight loss effect as well. So clearly, semaglutide 1 milligram is ideal for this person. But on the other hand, when you have a 45-year-old lady with a BMI of 33 and history of PCOS and also the CVD risk factors, then I want to give her the drug that has the higher efficacy when it comes to weight loss, if tolerated, of course. And that will be liraglutide 3 because it will address the obesity, it will address the PCOS based on the data we have, and also will reduce the CVD risk factors. So to conclude, why choosing semaglutide 1 milligram and liraglutide 3 milligrams? I think the semaglutide 1 milligram dose is clearly very beneficial for people with type 2 diabetes and will have some also beneficial weight loss effects in these people, but it will drive the glycemia down and have CVD benefit. The liraglutide 3 milligrams should be used for obesity management till you get the semaglutide 2.4, which has a greater efficacy. But it's important not to use the liraglutide for diabetes and not the other way around, because using semaglutide 1 milligram for obesity management doesn't give you the maximum weight loss, but also you may not get the health benefits that you see with the 2.4 milligrams in the clinical trial program. And with that, I'll stop here. Thank you very much for listening.
So thank you so much for a very enlightening lecture on a topic which is actually talk of the town nowadays. So I'll request my expert panel for a quick comment, please.
Thank you for asking my comments. Really, first of all, I would like to thank the speaker for his excellent talk on this topic of obesity and diabetes and GLP-1, which drug to choose. And I think he has given us a good knowledge about the mechanism of weight management and to decide which GLP-1 to use depending upon what is your priority. For diabetes, the dose is different. For weight, the dose is different. And liraglutide is primarily at 3 milligrams is for diabetes and 1 milligram of semaglutide is for diabetes management. So I think my comment is that we are going to use this drug more and more. And I think the only hindrance to us is the cost. Otherwise, this is a drug which is very good drug, very popular drug across the world with multiple benefits in terms of diabetes management, obesity management, CVD risk reduction, all that is there, whatever you would like to be in the ideal drug, except that the side effects, which takes time for the body to adjust. So I think it's the era of GLP-1.
Thank you, sir.
Thank you, Dr. Tahrani, for that very eloquent talk. Obesity is the bane of human existence at this point, with, as shown, affecting the entire world with all its consequences. But we are also living in very interesting times because whereas previously all we managed to do was blame the patient for eating too much and not exercising, we actually have very tangible solutions. And here he described 2 drugs. We first experienced liraglutide, daily injection, and semaglutide for diabetes. We are seeing weight loss with that dose as well, but waiting for the higher dose formulation to be available here. Not just that, we also know that in the pipeline are a plethora of products of mainly from the gut hormones and other mechanisms. So we are excited in the sense that it seems that we will have even better solutions in the future. Thank you very much.
Thank you.
Thank you so much, man.
One
In the
question.
interest of time,
One
we'll take
question.
one question.
Yes.
Yes.
Sir, you gave 2 examples of obese patients. Both have weight less than 100 kg. But if you have a patient, diabetes, hypertension, and weight more than 120 kg, and then what is the criteria? What is cut line where we should straightway go to surgery rather than these drugs?
Yeah.
Thank you.
So if you asked me this question last year, I would say if your BMI above 35 and you have type 2 diabetes, I would really recommend to go for surgery. Having said that, I've seen some really not a small number of cases who received either semaglutide or liraglutide for weight management with type 2 diabetes who actually really responded extremely well. So they are not the majority. But if the patient wants surgery, then I would think if BMI above 35 with type 2 diabetes, surgery is the best treatment option up till now because we don't have head-to-head data. But it is not wrong to try them on one of the obesity pharmacotherapy agents because some of them are super responders and they really respond so well and then actually they don't need the surgery. But that's if the patient wants to avoid surgery as well. And there is a cost to both options, they have costs. So it depends what the patient wants. But clearly, because type 2 diabetes lose less weight usually, I would prefer surgery for the heavier patients with type 2 diabetes. But I've seen some super responders. So now I give it a try. And then if they are willing to try, and then decide.
Thank you so much. Thank you so much, sir. And thank you so much to our expert panel. We are towards the end of our day's activities.